Good evening to all the aspirants present today. Today class topic is metabolic disease, and the speaker that we have here is Dr. Vinod Jaiswal. He is a consultant critical care at Royal Specialty Hospital at Dubai. Thank you. Sir, you may take over. Many more students will be joining us. Thank you.
Okay, okay. Hi, sorry guys. Good evening, everyone. I hope you are doing well. Uh, can we start?
Yes, sir.
Fatma, just one question. It's a two-way communication, right? Anyone can answer or something. How is that?
Yes, sir. It's an interactive session.
Hmm.
All the aspirants are requested to kindly unmute the mics regarding if any questions you have, or you can also put in the chat box.
Okay,
Okay? Thank you.
thank you. Good evening, everyone. I'm Dr. Vinod Jaiswal. This is one of the first lecture to teach you about MRCP Part 1 and Part 2 some topics. So out of the metabolic diseases, I'll be covering today disorders of metals and metalloproteins. Let's begin, I think, without wasting any further time. The pattern is like that. There will be some questions in the beginning, and then we'll have a theoretical discussion, and then we'll come back to questions again. All right. So if you want to guys write in the chat box, you can write. 1 second. Yeah. So yeah, this is a 19-year-old man present with slurred speech, tremor, and recent behavioral changes. He has a brother who died of liver failure at 25. Slit lamp shows KF rings. Which of the following lab findings support the diagnosis? You guys can write if you want to write in the box, or we'll come back later on and answer the questions. Okay, if you can write, no problem. A, B, C, D, E, everybody, if you can write, then we can see the answers later on. All right, we'll move in. Okay, we'll move forward. So second question, which of the following is the most common neurological symptom of Wilson disease? You can type your answers. Give some time. Okay. Wilson's disease, which pattern of inheritance and what gene is mutated? Next one. A 17-year-old girl is admitted with jaundice and ascites. She has no alcohol history. Lab shows elevated ALT, AST, low alkaline phosphatase, and coagulopathy. Ceruloplasmin is 0.15 gram per liter. What is the most appropriate next step? Okay, I think by this time the questions you must have guessed that the topic first we will discuss is Wilson disease. Okay, this is a very common topic you must be knowing, and this is also a topic in PSS exam as well. All right, so we'll discuss about Wilson disease. It's also called as hepatolenticular degeneration. Of course, the genetic disorders of copper metabolism. It's a recessive disease. 1 second. The basic dysfunction is that the copper transport is a problem, and the gene responsible for is ATP7B. So it is very easy to remember ATP, ATP molecules for energies which are produced in Krebs cycle and other cycles. Okay, and which ultimately leads to reduce biliary excretion of copper, and it gets circulated in the blood. and gets accumulated majorly in liver, but other organs as well, like brain, and they can have neurological development. Pathogenesis, sorry, the A is missing here. So ATP mediates the transport of copper, which turns the apoceruloplasmin to ceruloplasmin, and then ceruloplasmin is secreted in the bloodstream. This is a normal metabolism of copper. So when the gene mutation is there, the transport of copper is prevented. If the transport of copper is prevented, the apoceruloplasmin cannot be converted into ceruloplasmin, and that leads to excessive copper spillage in the blood. And when the copper is in the bloodstream, or when it reaches the different organs, we'll come to that also in some time, which mainly the hepatic cells. It leads to hepatocellular injury because of radical production or oxidative injury to cellular organelles. So basically, increased copper levels and hepatocyte damage results in the whole spectrum of disease in Wilson's. Actually, the free copper, not the ceruloplasmin, which is the active available copper in the blood, but the free serum copper, which is toxic to the liver cells and other tissues like brain. I hope you understand the pathophysiology. Any question here? If you want to ask, can ask, guys. No issues. Okay, so we'll look at the clinical features. First, with age presentation, generally is unlikely below 3 years of age, but from above 3 years to fourth or fifth decade of life, the Wilson's can present. Basically, manifestations of copper accumulation in different organs like liver. It can have all the manifestations from acute hepatitis to fulminant hepatic failure needing urgent transplant. So, from abdominal pain, jaundice, hepatomegaly, then signs and symptoms because of increased portal hypertension, varices, bleeding, signs and symptoms due to chronic liver disease because of copper accumulation. So most of the things of entire liver spectrum you can see when the copper is deposited in the liver. In the laboratory test, you will find low levels of serum ceruloplasmin. As you know that the copper transport is prevented, the ceruloplasmin is not forming, but though not every time the ceruloplasmin level may be low, it may be normal. But with acute liver failure, it's generally low. Then, of course, elevated liver enzymes, low alkaline phosphatase, thrombocytopenia, coagulopathy, and non-immune hemolytic anemia. Of course, you can do bedside clinical testing. So apart from that, you can do abdominal imaging, and you can find from steatosis, from hepatomegaly to cirrhosis, and all the features of chronic liver disease and acute liver failure. Neurologic involvement, the second most common organ involved is brain. Symptoms ranging from dysarthria, which is the very most common, up to 97% of the patients with high levels of copper can get dysarthria. Then cerebellar ataxia, abnormal gait, dystonia, tremor, and Parkinsonism, choreoathetosis, cognitive impairment, of course, and psychiatric symptoms also these patients can have. This is also one of the distinguished differential diagnosis in the PACES exam as well. When you get Parkinson disease or any patient with tremor, it could be essential tremor or Parkinson or with the Wilson's. This is a classical involvement you must have, guys. I don't know, in real life you had a chance to see. I think I haven't seen a KF ring. I think one time in my MBBS, I don't remember though. The KF ring is very, although not the 100% pathognomic, but yes, when the KF ring is positive, certainly you have to rule out Wilson's. Basically, copper gets deposited in the Descemet's membrane, and you can see a fine pigmented granular deposit, brown golden color on the periphery of the cornea. These are found nearly almost every patient who has a neurologic involvement, but not necessarily patient with the liver disease. And sometimes, yeah, you can get deposits in the lens, so which is called as a sunflower cataract. And this is not visible with the naked eye. You need to have a slit lamp examination. As we discussed, the two common organs which are involved, the liver and the brain, there are several other organs can be involved in Wilson's disease, which are kidney can cause Fanconi syndrome, which you know that which leads to proximal tubular dysfunction, then multiple metabolic abnormalities like glycosuria, amino aciduria, and proximal and distal renal tubular acidosis, which further can cause nephrolithiasis. Myopathy, proximal limb muscle weakness, arthropathy, arthritis is very common. We cannot differentiate the arthropathy caused by the pseudo gout, which is chondrocalcinosis. It's most commonly in the knee joint. You cannot distinguish actually. Then cardiac, of course, cardiomyopathy is a high chance of cardiomyopathy. There was one MCQ also. We'll go back to all the questions again. Endocrine organs, hypoparathyroidism, gigantism, female infertility, recurrent pregnancy loss, of course, male sexual dysfunction. In the dermatological, there is blue lunulae, then acanthosis nigricans. This you must have seen in different patients, and pre-tribal hyperpigmentation, which is also seen in hyperthyroidism or toxic nodular goiter or Graves' disease rather. And as we mentioned, hemolysis, Coombs negative hemolytic anemia. So these are the mainly organs involved: the liver, the brain, the joint, knee joint, chondrocalcinosis, cardiac, some dermatological, and some renal problems, though very common. Once you have come across how to make a diagnosis of Wilson's, so you need to have a high index of suspicion. Of course, when there is a family history, then it's easy to screen and look for a diagnosis. But you need to be high index of suspicion, and when to suspect, there are some criteria. Like unexplained liver abnormalities are there, along with particularly if they have a neurologic or psychiatric symptoms. When there is a low ceruloplasmin, less than 17 to 20, and very high suspicion if it is less than 14 milligram per deciliter. A first degree relative with Wilson disease, as we discussed. Any chronic liver disease or cirrhosis when the cause is uncertain, as we know that 50% of the Wilson's patient may not have KF ring positive. So you need to have a high index of suspicion, and for the diagnosis you need to send some test, which I'll tell in a few slides. Of course, acute liver failure with other combinations of Wilson disease. So you need to have a high index of suspicion. What we do is initial testing. There are 3 tests must be done. Ocular slit lamp examination, as we discussed, that is not visible to naked eye. You need a slit lamp examination for KF ring. Then the 2 most common tests, and the most important is 24-hour urinary copper excretion and serum ceruloplasmin. So as the copper is getting excess in the blood, so it is get filtered by the kidney. So urinary copper, 24-hour urinary copper excretion will be more, and ceruloplasmin will be low. Alongside, you will of course evaluate other organ functions, liver functions. All the serum copper concentration is nothing to do with the diagnosis, but yes, serum copper can be normal or high despite low ceruloplasmin. Then you evaluate for hemolytic anemia, other organ functions. You need to have a, we were here. Yeah, so the 3 tests which are important, and then you look for the end organ damage by copper. We can evaluate every organ in the body and do the assessment. Yeah, so how we make the diagnosis? As we know that we are doing 3 tests. KF ring, 24-hour urinary copper excretion, and serum ceruloplasmin. So there are two kinds of patients when depending on the KF ring. If the KF ring is present, so the 24-hour urinary copper excretion less than 40 microgram in 24 hours plus ceruloplasmin less than 20 is the diagnostic criteria, or serum copper excretion, urine copper excretion more than 100 mics per 24 hours, regardless of ceruloplasmin level. And patients without KF ring, it's of course the 24-hour urinary copper excretion has to be on higher side, that is 100 microgram in 24 hours, in addition to ceruloplasmin less than 10. So KF rings make the diagnosis relatively easy, and the thresholds are little bit uh, low when the KF ring is present, but without KF ring, the threshold is little bit high. Of course, these values may not be asked in the MCQs, but you never know. So it's better to remember the values. Liver biopsy also can diagnose, as sometimes there may not be test or indeterminate or in between the lab values. So then liver biopsy also can make a diagnosis. So it can be established if it's more than 250 microgram per gram of dry weight when the copper concentration, and it's excluded when it is less than 50 microgram per dry weight. This is how you diagnose by liver biopsy. So we come from pathophysiology, clinical features, how to diagnose and evaluate, and we'll come to the treatment part of Wilson's. So goals of therapy, of course, you remove copper from the accumulated tissue, prevent again accumulating in the tissues, improving symptoms, and maintain the liver functions for a longer period of time. General measures, there are you avoid excessive copper containing foods like seafood, shellfish, and all. Immunizations keep up to date. Of course, abstain from alcohol or any other drugs which are toxic to the liver. The initial therapy, patients with symptoms or an organ damage. Of course, there's a copper chelating agents like D-penicillamine or trietine, the first line therapy. Either of them can be tried, and the efficacy is similar. Particularly, trientine is helpful when you have a D-penicillamine toxicity, like liver, kidney failure, or severe thrombocytopenia. Then trientine may be helpful better. And sorry, yeah. So once you initiate the treatments, most have some improvement within 2 to 6 months in the symptoms and their biochemistry. Then they get stabilized over next 2 years, and the recovery slowly continues gradually over the several years. Those for the symptomatic patient, again, even if patient is asymptomatic without organ damage, then you can choose either D-penicillamine or trientine or zinc. Zinc also helps and equally efficacious if you want to avoid the toxic depenicillamine and asymptomatic patients. And of course, they are when patients are non-responders, you can combine all the three. And if not failure to that, then the liver transplantation is the only cure for the in non-responders. Of course, you have to keep look into particular kind of patient with pregnancy and lactation. Although they are not contraindicated, and therapy should be continued because damage by copper and is more than the treatment. So, although the dose has to be reduced to 25 to 50% in pregnancy and lactation. Guys, finished the sorry, Wilson's I finished. Should we go back to the questions? Uh, Anybody want to answer can answer, guys. So what are the answer for the first question? I saw some correct answers initially, and some were wrong too. So the answer is C, elevated 24-hour urine copper. Elevated serum ceruloplasmin, of course, no. It has to be low or normal. Elevated serum copper, yes, possible, but it can be normal. But the diagnostic is elevated 24-hour urine copper. And the last two are for hemochromatosis. So next question was, yeah? Someone is asking? Hello? Should we continue? Second question? All right. Which of the following is the most common neurological symptom in Wilson? We can put your answers in chat box, or anybody want to answer can answer. Fatma, yeah, they can unmute themselves, right?
Yes, sir, they can.
Okay. So it's a difficult question. Sorry, 1 second. Yeah. So in this, when if you go back to my slides, the dysarthria, cerebral ataxia are the more common. But out of this, Parkinsonism is the most common in this question. But but options can be different in the exam. So chorea, of course, come below Parkinsonism. Seizure also come below Parkinsonism. So mostly will be dysarthria, cerebral ataxia, Parkinsonism, then chorea, and then other things will come. So here the answer is B. So which pattern of inheritance and what gene is mutated? It's very simple. You can remember ATP. So it's autosomal recessive. Option is C. Although this is maybe can be a I'm saying MRCP part 2 question. So this is a 17-year-old girl with jaundice, with ascites, no alcohol history, LTST is elevated, low alkaline phosphatase, coagulopathy, ceruloplasmin is low. So it's diagnosis is you have to make the diagnosis first here. What is the diagnosis? Okay. So all the only hint is here no alcohol use and the ceruloplasmin level. Otherwise, it can be any chronic liver disease or acute liver disease going in for fulminant hepatic failure. So here, despite even the diagnosis is Wilson, we don't have time for oral chelating agent. So the patient need is urgent liver transplant evaluation. Okay, the A option is not suitable. Other options are, of course, not suitable. The option is B here. Just she has to go for urgent liver transplant. Uh, any questions, guys? These 4 questions are done, and Wilson is over. Should we move to the next part? Any doubt on Wilson? Hello? Can raise hand, or you want to talk? You want to chat box? Anything? Any questions?
So far, no, sir.
Great. Okay. Okay, then we'll move forward. Again, question based initially. You guys try to answer. I'll give you 5 to 10 seconds to reply. A 52-year-old man is referred due to raised ALT. He complains of fatigue and joint pain. Lab shows ferritin of 900 microgram per liter, transferrin saturation 85%, and mildly raised glucose. Which is the next best step? Anybody wants to answer? They can answer. They can talk. They can want to write in the chat box. Anything is possible. You got one answer. Let's move to the next question. What is the most likely cause of arthropathy in hemochromatosis? Which one of the following is a recognized cardiac complication of untreated hereditary hemochromatosis? This is a tricky question. Which of the following HFE gene mutation is most commonly associated with hereditary hemochromatosis? Guys can answer, no problem, guys. Even if it is wrong, doesn't matter. But you try to attempt the questions. Anyway, we'll come back again once we go over the theory.
282Y. 282Y.
Okay. So C or D? Both are 282Y.
No, C. C.
Yes. Which joint is most commonly affected in hereditary hemochromatosis?
Knee joint.
Okay, we'll see. A 55-year-old man has a ferritin of 850 microgram per liter and transferrin saturation of 88%. Which combination best describe this pattern?
So C. Answer C.
Hmm. Okay. So, okay. And you guys understood that this is we're talking about hemochromatosis. Again, this is very common topic for the questions, and plus it's a very common case in PACES exam, more than Wilson's. Wilson's also is very rare to have an examination. But hemochromatosis is very often you will find cases in PACES exam, but questions in MRCP part 1, part 2 as well. Okay. So we'll go briefly over the theory and try to cover all the topics and the questions. So of course it's hereditary. There are several non-hereditary causes also. I did not purposefully include in that in this discussion, but we can have some discussion at the end if you guys want. So it's of course the mutation in C282Y, C282Y, HFE gene. It has to be homozygosity. Even if when this coupled with the diagnostic evaluation and mutation, the diagnosis can be confirmed, but presence of genetic mutation is not necessary. That even if the patient, someone has this mutation, it's not 100% necessary that the patient will develop hemochromatosis. All right. Um, this mutation cause, of course, increased intestinal iron absorption and leads to total iron body overload, which gets deposited into the various organs. Actually, virtually every organ have iron depositions. And even that, as I mentioned, not all the individual with this variant develop iron overload. Mostly white Europeans, very common to have a hemochromatosis. But acquired hemochromatosis or iatrogenic with the therapy is also quite common in any part of the population, particularly in Middle East,
লোকটাকে পাঠিয়ে দিবি
where we have multiple transfusions in thalassemia or sickle cell. It's quite common. And even though it was considered rare, hereditary hemochromatosis the incidence is increasing nowadays. Okay. So again, it's an autosomal recessive. Wilson was also autosomal recessive. This is also autosomal recessive. Generally, it's a disease of chronic iron overload over the years. Okay, so it takes decades to get iron deposited and accumulated in the body. Okay, so the retained or increased iron in the body get deposited, particularly in the parenchymal cells, most preferably initially in the periportal hepatocytes, and then it goes into the reticuloendothelial cells. Okay. In contrast, with the acquired or secondary hemochromatosis is due to blood transfusion or iron overload. The iron deposition occurs first in reticuloendothelial cells and then in the parenchymal cells. Okay. And as you must be knowing, the iron gets accumulated preferentially in liver, heart, pituitary gland, pancreas, and other tissues, and accordingly, patients will have manifestations of different organs. So generally, in normal dietary intake, around 1 milligram of iron is get absorbed in the body. But with patients with HH, the iron absorption is as high as 3 to 4 milligram per day. So imagine like 3 to 4 milligram per day, and you need 20 to 30 grams of iron deposit in the body to have a symptom. So it takes almost 2 to 3 decades to get the symptoms. So that way we won't find manifestations in earlier than third or fourth decade in males. Okay. So as just discussed, the typically the males present after M40, and generally females, it occurs less because they have a regular loss of iron and blood through menstruation, so they get further in down their life. Okay. Chronic fatigue, skin hyperpigmentation, some joint pain, generalized joint stiffness, one of very common findings in hereditary hemochromatosis before the organ gets involved. So these are very non-specific. So there has to be very high index of suspicion, or if you know that any first degree relative is having this condition, then you have to screen them early because potentially curable and treatable condition. So the liver gets liver functional abnormality 75%, weakness, lethargy, skin hyperpigmentation up to 70%, diabetes mellitus we call as the bronze diabetes, then arthralgia, then involvement of sexual organs or impotence in males, amenorrhea in females. And if the heart gets involved, then of course electrocardiographic abnormality is 31%. Okay. So we'll go by organ, what happens, how it goes. So as we discussed, it can be deposited in any organ in the body, mostly hepatomegaly. Then it will cause increase in transaminases, fibrosis, leading to cellular cirrhosis, and particularly very high risk for developing hepatocellular carcinoma when the patient develops cirrhosis. And as we'll see further in the down, the treatment doesn't change cirrhosis. It doesn't have any effect on the cirrhosis. So you have to diagnose the disease before patient gets cirrhosis and treat it. And of course, the reversibility of the hepatic injury depends on how early you diagnose and how early you start the treatment. Okay. Even though cirrhosis is there, there is some evidence that maybe some early whenever you start the treatment, even patient has cirrhosis, there may be slight regression in the fibrosis, although majority doesn't happen. Cardiac overload, one of the question was on this. So basically dilated cardiomyopathy is the most common. Everybody thinks that the restrictive cardiomyopathy is the common, no, but it's the dilated cardiomyopathy and conduction abnormality are the common when the iron get deposited in the cardiac tissues. Okay. And it can be assessed by MRI. And of course, as with hepatic abnormalities, cardiac abnormalities can be reversible in some patients after starting the treatment. Endocrine organs, pancreas, pituitary gland, all other endocrine organs can be involved, leading to further hypopituitarism or hypogonadism and hypothyroidism, decreased libido, impotence in males, amenorrhea in females. Of course, with the hypogonadism, there will be low bone mineral density. And diabetes mellitus is very common, although it's type 2. And it doesn't affect any other part of the pancreas, rather only pancreatic beta cells. So glucagon secretion and other pancreatic secretion doesn't get affected by iron overload. Arthropathy, one of the questions was also on arthropathy. Is very common to have a predilection for second and third metacarpophalangeal joints, but we don't know why those joints are preferentially get involved, but is indistinguishable from calcium pyrophosphate crystal deposition. So it is called as chondrocalcinosis mostly. But chondrocalcinosis or calcium pyrophosphate deposition due to iron, not the pseudogout or something. And iron removal, generally, there is no effect on the arthropathy in general. So it's a mostly irreversible damage. Of course, it get deposited in the skin, so it's called as bronze skin. And the classic triad used to be called as cirrhosis, diabetes, and skin pigmentation. But it's so late if you to get this classical typical triad. Now the patients are getting really diagnosed earlier because of the different screening, or if they know that first degree relative is affected. So the typical bronze diabetes, having cirrhosis, diabetes, and skin pigmentation is not so early because it's a very delayed and late presentation. It also increase risk to infections, which are some microbes which thrive in high iron environment like Yersinia, Vibrio, and Listeria. As I discussed earlier also, once the cirrhosis is developed, the chances of getting hepatocellular carcinoma is very high. So has to be treated before the cirrhosis has been diagnosed. And of course, other tumors of the liver like cholangiocarcinoma can also occur. Let's look at the diagnostic evaluation, how you diagnose, because the questions will be on this. So you suspect with any of the following symptoms like unexplained fatigue, clinical signs suggestive of iron overload like skin pigmentation, arthropathy, arthralgia, chronic liver disease, undiagnosed, unknown or undiagnosed cardiac failure, type 2 diabetes mellitus. So any of the segments symptoms we have discussed earlier, so has to be a high index of suspicion with arthropathy. And of course, if first degree, second degree relative is there, you have to suspect, and early evaluation is important. So these are the diagnostic criteria on the labs. So of course, unexplained liver function test and high serum ferritin, particularly more than 300 nanogram per ml in males or postmenopausal females, because they have stopped their menstruation. So the criteria for both is same. But premenopausal, more than 200 nanogram per ml is enough to diagnose. And high transferrin saturation, more than 45%. Right. So this is the diagnostic criteria. Other things can be done when this criteria doesn't fulfill or a high index of suspicion is there. They can do MRI, cardiac and liver MRI, and it can give estimation of iron stores. That's I think radiologist job to give us the how much iron overload is there. And some patient, if still diagnosis is not possible, then liver biopsy can be done. And most importantly, if you diagnose a patient with HH, you have to screen for genetic testing, because to find out the gene mutation and to screen and follow up on the other siblings or the first degree relatives of the affected patient. So this is not important for the patient per se, but for the further generations and all, how to go about the genetic screening for other siblings and the first degree relatives. So it is important. Okay. Suggested evaluation. So as I discussed, when every organ you can go and assess. If weakness, fatigue is there, evaluate for the liver, endocrinology, cardiac disorders. Um, Even you diagnosed before even reaching diagnosis, you should rule out the chronic causes of chronic liver disease like hepatitis B, C, and drug induced and other things. Um, Orthopathy, you can do radiographs, thyroid functions, then like hypopituitarism, hypogonadism, so testing for the hormones, then cardiac MRI, ECG, echo, and of course for diabetes. So these are all the end organ damage. You have to assess the damage and evaluate them, because if you go further down, most of the organ damage are rather doesn't recover even despite initiating the therapy. So this is really is a treatable and preventable condition, but you have to diagnose in time and when the damage has not been done. Management as we go. So the main management, of course, is a phlebotomy. You remove blood and depending on the levels. And those who cannot tolerate, maybe patients sometimes, despite having iron overload, they may be anemic. They may not tolerate the phlebotomy. Then you have to use iron chelator instead of phlebotomy, so like deferoxamine or something. Okay. And people with organ injury has to be rapid and aggressive intervention is required to prevent the further damage and complications. Okay. So you initiate phlebotomy when ferritin is like if you diagnose the patient as symptomatic and no damage is there, so then you can initiate when the serum ferritin is more than 300 in males and 200 in females, especially if more than 1000 nanogram, then you need to aggressive treatment. Okay. Then evidence of organ damage is there on MRI or clinical, whatever evaluation we have done. So generally phlebotomy is done once or sometimes even twice a week when you need aggressive treatment. And the goal is always like to keep the serum ferritin less than 50 nanogram per ml and ferritin saturation less than 50%. Okay, generally, it takes 6 to 7 months to go down to this level. And then you can reduce the frequency of phlebotomy and keep monitoring like once a month, and then keep monitoring them for the organ damage and reaccumulation of serum ferritin and all. So this is the about phlebotomy. As I discussed earlier, so this is the list where phlebotomy in conditions where phlebotomy helps, and in some organ damage phlebotomy doesn't help. If patient has no complications, everything can be prevented and he can have a normal life expectancy. Okay. Symptoms, majority of the symptoms like weakness, fatigue, they have improvement after the starting phlebotomy. Okay. Uh, Enzymes also decrease to markedly. Hepatomegaly resolution occurs, but hepatic cirrhosis, as I told you, there is no change once the hepatic cirrhosis has been developed. Increased risk of primary liver cancer, there is no change. If patient has already cirrhosis, so there are very high risk to develop HCC or other kinds of like cholangiocarcinoma. Other symptoms like upper right quadrant pain, mark improvement. Arthropathy, there's hardly any improvement after starting the treatment. Hypogonadism, again, there is resolution is very rare. Diabetes, may some improvement, but again, temporary improvement is there. Hypothyroidism, there is no resolution. Cardiomyopathy, so some benefit occurs, not complete. Hyperpigmentation, also some resolution, not completely. Hyperferritinemia, of course, we are doing phlebotomy, so they will be resolved. Okay. And infection with other bacteria, there is still high risk of infection. They also doesn't get resolved. We'll go back to questions, guys. Anything you want to ask before we go back to questions?
Sir, Dr. Das, I'm asking one question. Thank
Yeah.
you for elaborative lecture.
Yeah.
What is the first investigation of hematochromatosis?
For diagnosis, when you have high index of suspicion, you mean?
Diagnosis.
Yeah. So serum ferritin and transferrin saturation, these are the most to clinical diagnosis. Yes. And then
Yes,
along
yes.
with that, you have to do gene mutation to confirmation. These three things are required.
Sir, what is gold standard investigation for hematochromatosis? Gold standard investigation?
It is always combination. If you are give depending on what options you have, there is a gold standard means ferritin and transferrin saturation, as I told, more than 300 and more than 50% transferrin saturation. But none of them is there, then gene mutation is the. Having said that, even if you have a gene mutation, it's not likely that everybody will develop a disease. Correct?
Yes.
So
Sir,
ferritin.
any role of liver biopsy?
Huh?
Any role of liver biopsy?
Liver biopsy, yes. If you want to diagnose, yes, liver biopsy also one of the tests. But then depending on all the options, liver biopsy is not always the first choice.
No, no, no. No, no, no.
Sorry.
No, no, it is not the first investigation.
Yeah, it's liver biopsy when you have still doubt and you want to estimate how much iron deposit or iron overload is in the liver
Yes,
for
yes.
propagation or for treatment purpose, maybe
Yes.
for diagnosis. But if out of the options, if you don't have all these three things, transferrin, saturation, or ferritin, see, alone you cannot diagnose. Ferritin can be raised in many conditions, correct? So
Yes.
yeah, given the choice and options, if you have given, so depending on the clinical context and all, it's always a tricky question what you want to answer. You read the question carefully, you read the hemochromatosis, how it is diagnosed in different conditions, and then treat. Like if you see the first question here, okay. Any further doubt on this or clear,
Yes. Yes.
Dr. Das?
Yes. Yes. Thank you, sir. Sir,
Okay.
in case of acute phase reactant, ferritin will be raised. In that
Yes.
time, how can we assess?
Yes, but then you have to rule out, no, any patient has any acute phase reactant or no clinically, correct? Then you have to take transferrin saturation,
Yes. Yes. Yes.
right? So
Yes.
these two things, and if these two things not, then gene mutation, and if these all three options are not there, then the biopsy, because
Yes.
it will show the direct deposits, no, in heart and liver, it will show you the direct deposits. Even the MRI can be done, and they can estimate the iron overload. So depending on the context of the question, you can answer this one.
Yes. Yes.
All right. So here, as the patient looks like clearly hereditary hematocrosis, like patient has diabetes also, patient has liver dysfunction, fatigue, joint pains. So it's very straightforward. Like here's also there's some mention order liver biopsy immediately, bone marrow aspirate, start chelation therapy. But here you will do first confirm the diagnosis. You mostly suspected it, all the things are there. Of course, iron you will not start. Chelation therapy will not start because he will need if diagnosis HH, then you have to start phlebotomy. Liver biopsy is there, so it is a confusion here. You can go for liver biopsy also and for HFE gene mutation also. So, but the most diagnostic will be HFE gene mutation here. That is the next step. All right.
Yes.
What is the most likely cause of arthropathy in hemochromatosis? Um, this is
That is
actually,
chondrocalcinosis.
yeah, this is yeah. Even the B option is okay. If you don't have chondrocalcinosis, you can tick B also, but the most appropriate is chondrocalcinosis because the other name only. Because of iron deposition, we call it as a chondrocalcination, but indistinguishable from calcium pyrophosphate deposition. But if both the options are there, then you choose chondrocalcinosis. Which of the following is recognized cardiac complication of untreated hereditary hemochromatosis? We discussed already.
There are already dilated cardiomyopathy.
Yes, I have seen some of the answers as a restrictive, but because it's logical to think as something deposit in the heart, you will have a restrictive or constrictive cardiomyopathy, correct? But no, here it is a dilated cardiomyopathy. This is straightforward. I think we discussed already before somebody answered. Yeah, which joint commonly involved?
The second and third metacarpal
Yeah,
carpophalangeal.
yeah. Somebody has said knee, but knee is common in Wilson's, not in hemochromatosis. So second and third metacarpophalangeal joints very commonly involved, although we don't know the mechanism and the predilection why the second and third metacarpophalangeal joints. One question left, I think. Yeah, this was also very straightforward. Okay, we can discuss the other options. High ferritin, low transferrin saturation. Is true of chronic disease? No, chronic disease also will have high transferrin saturation, correct? High ferritin, high transferrin saturation. That's also wrong, so that's not correct. High ferritin, normal transferrin saturation, non-alcoholic fatty liver disease. Why they will have high ferritin? So I don't think it doesn't go. High ferritin, high transferrin saturation, iron low. Yeah, this looks correct. Low ferritin, high transferrin saturation, of course, no. Iron deficiency will have a low transferrin saturation also, and increasing TIBC. Low ferritin, low transferrin, thalassemia trait. What do you expect in this? This one is tricky little bit. Thalassemia trait will not have blood transfusion really, so it's unlikely that he has a low ferritin. Low transferrin saturation is still possible, but will not be iron deficiency on low ferritin, I think. So most appropriate looks C option. Yeah. This is what today, guys. This was my first with this academy. So I take the class first time. Today only I had the time to prepare. I'm working today also, so I had the time to prepare. So today only I prepared these slides. Uh, Try to cover comprehensively these two topics because very common. I wanted to take porphyria also, but if we include porphyria, it will take a lot of time. So these are the two topics I thought I should cover today, which I know also a little bit very well. So I thought start with the common and easy topic. Any questions, guys?
No, sir. Thank you, sir. Elaborative for
I hope you guys enjoyed.
yes, yes.
Let me know next time onwards. I think Fatma can also coordinate. This pattern looks okay, or want something change something. Too much information was there. What do you guys think? So my aim was to when you go through a topic, so it should help you through part one, part two, and plus spaces as well. So I tried to include what are the common questions they will ask in Wilson's, in paces, what are the common questions they will ask in exam. So that was I was trying to do. But let me know you guys your feedback. Any particular change you want? You don't want any questions, uh, or questions where I think okay.
Sir, what are the next topic?
I'll
Finish.
discuss it for Fatima because they have given me metabolic diseases. It has a big list actually. You guys have any preference? I'll read the topic just 1 second. I can show you. You can see my screen still, right? So these are the topics. Metabolic disease covers. It's a big list. But I think very few questions on this disorders of amino acid metabolism. Gout, yeah, there will be some questions. That's why I took this topic because the common topic. Lipid metabolism also there will not be much. Yeah. Disorders of mineral and bone, yeah, these are very all common topics. Obesity, acidosis, I can teach anytime. Which topics have been covered apart from these, doctors? Any other
Yes,
topic?
sir.
Any other topic has been covered from this list?
I cannot read
You
too
cannot
much.
read. This is maximum zoom I can do. No worries. Fatma can share with you this list of topics. You can tell me any other specific topic you want. Then we.
Sir, regarding calcium metabolism, hyper or hypo, phosphate metabolism, hyper and hypo, magnesium metabolism,
Hmm.
can you add?
Magnesium, I don't think they ask. They will ask on page 8, osteomalacia,
Yes,
lab,
yes.
hypo.
Yes, osteomalacia.
Yeah, these things are common. I don't.
Paget's disease also.
Yeah, Paget disease is very common. Even the PACES, if the Paget disease is there in any patient, they will keep the patient in the PACES exam. If you find a Paget disease, they will keep. Then metabolic acidosis, alcoholysis, maybe some questions that I can teach you. I don't need a PPT to teach them, teach those things. I can teach you straight away anytime. Some questions may be there on that. Gout will be some questions. Lipid
Sir,
metabolic.
metabolic bone disease.
Okay.
Metabolic bone disease. Important subject, sir.
So that's all, no? Paget's, osteoporosis, multiple myeloma, all those things comes, no? Correct?
Yes, yes.
Yeah, I'll take next time. If you want this, I'll take this topic next time.
Thank you, sir. Thank you. Very nice lecture.
Thank you, guys. Thank you, Dr. Das. Anybody
Yes.
else want to ask anything, any feedback? Fatma, then we'll end the session.
Sure, sir. We can conclude this session. So I'll be scheduling the next class really soon. So all the students are hereby informed to be connected in the WhatsApp group. Thank you.